Hello, this is Chapter 2 lecture video part 2. So Chapter 2 is historical perspectives, and we're going to conclude this part of the textbook, this chapter. The second part of this lecture video focuses a little bit on the history of treatment. So the history of addiction treatment, kind of how it started, where some of its roots came from, and leading up to what we have for treatment today. So during the second half of the 19th century, there was an increase in medical awareness about addiction. And that brought it to surface. That brought it to light that, hey, there is this concept of addiction. We need to find ways to treat people that suffer from this addiction, this alcohol misuse. And there was also an increase in institutions that were specializing in the treatment of addictions and during this time period as well. So remember, we talked about the prohibition in the first lecture video. So that ended in 1933. The population started to view alcoholics as sick and not sinful. So that's kind of where another one of those views that we talked about in that first chapter is, how do people view alcoholics? At this time, society was starting to view them as sick and not sinful. And with that being said, if people are sick, then we need to find ways to be able to help them or to treat them. So this is where treatment became more important or more popular. Some social work pioneers kind of helped with legislation that established these different types of institutions that we had. Those of you who are in the social work profession or for your career will know the name Jane Addams. Her belief was that alcoholism was a disease. She was around the time of 1909. She is definitely someone that we mentioned several times in social work. Also, the impact of social work pioneers on legislation and treatment programming started to decline at the start of the 21st century. So it was kind of a short-lived time period there, but they were the start or trying to help during that time frame. Alcoholics Anonymous was a more humane way to view alcohol addiction. It grew out of an evangelical Christian movement. It provided a meeting place for where people could share their struggles with sobriety. So we have two alcoholics that kind of started this, Bill W. and Dr. Bob. They were the ones that founded the 12 Steps and the founding principles of the AA program. It was based off of the disease concept, but Dr. Bob didn't really talk about it being a disease concept because I think he also was trying to avoid medical controversy. The core principles that emerged from this type of treatment were powerlessness, seeking divine guidance, making confession and restitution, and carrying the message to other persons. The publication of the Big Book was in 1939, and that Big Book kind of held all of these ideas or all these beliefs or views for people in AA. It was like a something tangible that they could hold on to that kind of held on to these values for them. Today, more than 2 million members in 150 countries hold meetings in church basements, school gyms, and hospital conference rooms for AA. And the concepts from the 12 Steps have been borrowed for other self-help groups such as NA, Narcotics Anonymous. There's Overeaters Anonymous, Gamblers Anonymous, Sex Addicts Anonymous, different types of programs, and each of them have their own version of the 12 Steps. So their work, Bill W. and Dr. Bob, is kind of carried on into other, anonymous type groups such as those. The publication, I'm sorry, I told you that already. AA tends to be more strict. When I was working in outpatient drug and alcohol, I would have clients come back and tell me, because I would encourage them, try an AA meeting, try an NA meeting, because depending on where a person lives, they might have more AA meetings or more NA meetings for whatever reasons. That just tends to be the type of meetings that are in that area. So I would encourage people, go out, try one of each, try different things, see what works best for you. And I would have people come back and tell me that they found that AA meetings tended to be more strict than NA meetings. This being said, I think it is because, AA was the first one. AA has its founding fathers, they had their strong views, they had their beliefs, and then NA stemmed off of it, and all the other types of meetings stemmed off of it. They tend to take it a little bit more serious, and they don't want people coming in there that aren't taking it serious. So they're more likely to kind of say, okay, well, maybe this isn't the meeting for you, or this isn't working. Not that they want to turn people away, but they want to keep their values strict so that they can continue to help themselves as well as help others that are serious about their recovery. One criticism of AA is that it doesn't change well with the times. They have a tendency to not be okay with prescription medication. I mean, not every group, not every meeting, but some meetings frown upon the use of medication, and they believe that, you should solely be absent, you should solely be just, alcohol free. So they don't think that taking a mood altering prescription is good to help with reducing cravings. Also, AA has a hard time if you are addicted to maybe multiple substances, or maybe if your sole thing is just drugs and there really isn't so much alcohol. So some things to kind of keep in mind. Again, this isn't every meeting. This is just some feedback from different clients that I worked with about AA. And the only requirement that you need to join AA is the desire to stop drinking. So anybody can do it. You don't need to be approved by insurance companies or wait on long waiting lists or anything like that. You just need a desire to quit, and you need to find a meeting, and it needs to be an open meeting that you could go to. They do have meetings that are closed meetings, and those are reserved to just like a select specific group that works. And those, again, would be the people that are very serious, very focused, very driven group. And then they have open meetings that anybody could go to. Anybody could go to an open meeting and just walk in. NA came along in 1949, but was officially founded in 1953. I wanted to take a minute to talk about Jelinek and his pioneering study. Jelinek was a statistician who conducted a systematic research on male AA members, known for developing the 5 species of alcoholism. So I wanted to, kind of review these with you. There was alpha alcoholism, an undisciplined use of alcoholic beverages. Drinking relieves emotional disturbance, but relationship problems are caused. There's no physiological dependence, but no progression for those who are in the alpha alcoholism category. There's also beta alcoholism. Heavy drinking causing physical complications such as cirrhosis of the liver, but without physical or psychological dependence on alcohol. So you could have the medical issues, but you're not physically or psychologically dependent on the substance. Gamma alcoholism is you have your increased tolerance, there's withdrawal symptoms present, and when the drinking stops, withdrawal symptoms are present when the drinking stops, and there is a sense of that loss of control, a marked progression, and relationships are impaired for this person. Delta alcoholism is similar to gamma, but without the loss of control, just a hard time to abstain for one day. No distressing social problems over the quantity consumed, but there could be health problems that arise. And then the last one is epsilon alcoholism, which is periodic alcoholism. So those would be considered your binge drinkers. Only gamma and delta alcoholisms are considered addiction or disease. So that's interesting. He has 5 species of it, but only those two are considered addiction or disease in his research. So what is the purpose of knowing this is the U curve. And this is a very, very tiny representation, but I wanted to show you. This is the U curve that Jelinek is very popular, very known for. And you can also see a larger and, get a closer look at this copy by clicking on the link that I will provide for you so that you can have access to this and you can take a little bit more time to read over it. So you can do that on your own as you choose to do so. But what I wanted to show you was on the left-hand side of your U curve here is kind of like the start of your addiction. So you're starting up top, but then you're kind of going down that slippery slope that you will hear in one of those terms that you would hear in addiction. The bottom, which I know it's really hard to see in this video, is right down here. This is kind of, I think, very symbolic to what you would know as your rock bottom. So a lot of people in addiction say that, you hit this rock bottom point. Rock bottom looks very different for every person. However, this is kind of just interesting how he made that U-shaped curve. And this would be kind of like that lowest point or that point of chronic phase. So this is definitely a point just to kind of, pick a couple things out there is obsession with drinking. You're completely defeated at this point. So very tiny reading there, but you can read a little bit more about that, like I said, in a bigger picture for you. Then when you start to go up the curve is when you're on that start to recovery. So you kind of go down, hit rock bottom, and kind of work your way back up and kind of start to be where you were prior to addiction. You'll never be the same person that you were before your addiction, but you'll be a new and improved person when you're working on recovery. So I wanted to talk about that. This U curve depicts the progression of alcoholism from social drinking to the full-blown loss of control. Again, that rock bottom is when you're at that full loss of control. All right, so moving on into some later developments. The Hazelden Treatment Center opened a farmhouse in Minnesota in 1949, and that was considered a sanitaria for drug and alcohol people. These were conceived to be snake pits that were run by quacks. So that's interesting view of what these, treatment interventions were back in the day. This was the view of medical professionals as well as the public, that once a person becomes an alcoholic, there's little chance that they could be recovered. This became known as the snake pit. So if you are labeled an addict, again, another reason why I hate labels is you're being thrown into this place, this snake pit, who's run by quacks, but you're not really able to recover. You're not really able to get out of it. So I think that was the symbolic emphasis on why they considered it a snake pit. But that was the snake pit era of treatment. Addicts were locked up in hospitals with the mental health patients, and they were considered hopeless or helpless. The Minnesota model, that was a later developing model, would emerge to take a multidisciplinary approach. From psychology, it took therapy. From the clergy, it took spirituality. From AA, it took the group-based treatment and the 12 steps. And so it encompassed a little bit about everything to help people get better. I like that multidisciplinary approach. It's good to maybe, again, you're working with people that not one type of treatment is going to work for everybody. So you're taking a little bit from other approaches and kind of adding one effective approach, hopefully. The key to this model was recovering non-professionally trained counselors as legitimate components of the treatment team. Something I wanted to kind of talk about here, since we've mentioned it, is they were taking people who aren't professionally trained, so they aren't going to school like you or I. Now, when I was doing outpatient treatment, that was always seemed to be a topic that would come up often with my clients is, one of their first questions was, well, are you a recovering addict? Well, no, I'm not a recovering addict. And sometimes that would change the view of the relationship between the client and myself. However, although it may, they're still entitled to their views and they may still view this as, well, I would like to work with someone, who has been down this road or had these experiences as me. I tell my clients all the time that I think that an ideal situation would be is you would have one of each. You would have that professional person that has been trained to work with these different types of theories or these different types of works. They know the history, they know the treatment, they know the addiction. But you also have a person from recovery, because that person is going to know addiction better than anybody knows it like you. They've been through the same experiences. They've been through rock bottom. They've been through these different things, but they've also recovered. So they can kind of help you through a little bit more of every step of the way than maybe the professional person could do. However, I don't think one makes any less than the other. I think you still need a professional person in this situation because, you want to have someone that knows how to effectively kind of help you or work with these different types of therapies so that you have a more successful chance of being recovered. So a lot of clients have mixed views on that in the field. In the 1970s, there were more than 30 separate agencies and departments of the federal government that were involved in some aspect of substance abuse treatment. So the new trend was drugs and alcohol treatment together. So it wasn't just treatment for alcohol or just treatment for drugs, but we were going to treat these two substances together. Inpatient programs at first typically only focused on alcohol. However, people would switch addictions. So that was always something that I would have with my clients as well, is this cross addiction. People don't believe that it's a true thing, but it is. You may start addicted to one substance, but then when you are slowly eliminating that substance, you fill that void with something else. That's where cross addiction comes in. And in the history of treatment approaches, cross addiction was something that emerged around this time. The fact that you could be addicted to more than one substance was an eye-opening experience. You're replacing one with another. In 1970, the Hughes Act was passed. It was named after a senator. It provided research funding by the federal government to improve services for alcoholics. It was known officially as the Comprehensive Alcoholism Prevention and Treatment Act. 1970, Betty Ford went public with her alcoholism. She did 28 days of inpatient treatment. Insurance coverage was available, and the media portrayed the accounts of celebrities in recovery following treatment as a positive experience. Sometimes we don't see it as positive in the media today. With everything, you're always going to have people that are kind of anti-something. So we have our anti-treatment backlash. The 1980 and 1990s, there was a backlash against addiction treatment, the Reagan era, and the zero tolerance of drug users. Court saw the religious aspect of AA and NA and made it a violation of the First Amendment to require court-mandated attendance at these meetings. So we have that separation of church and state. I can't tell you how many times that I worked with clients that would say, well, you can't make me go to AA. You can't make me go to NA. It's against my rights. It's against my views. Which, there is this First Amendment right. So again, there was that blurred line of that separation of church and state. So that is kind of recognized there. Available funding for treatment until recently was connected to the criminal justice system rather than to medically based services. This emerged the development of managed care. We'll talk a little bit more about that later in your book. But overall, managed care was positive in progressing the professionalization of the substance use treatment field. Insurance companies stressed that counselors needed academic requirements and qualifications as well as evidence-based treatment methods that they were practicing. And this took place in the latter part of the 20th century. Approved medication to reduce cravings, but it de-emphasized the importance of individual counseling. So we have this emerge of medication used to treat addiction, but it kind of took away from individual counseling. So we're relying solely on a medication and not so much as actually having a counselor to help somebody. So they're kind of rebelling against the individual treatment with that. Recession of 2008 led to the reduction of state funding for substance abuse treatment, known as the Mental Health Parity and Addiction Equity Act. Requires health insurers to provide the same level of benefits for substance abuse or mental health treatment as they do for medical needs. We also have the introduction of the harm reduction model. The concept of harm reduction first surfaced in the 1920s in the United Kingdom as the medical approach that called for prescribing heroin and cocaine to patients who were dependent on these drugs. The goal was to reduce the harm associated with their obtainment and use. So it's, again, we've mentioned this before, and we will continue to mention this, is that the harm reduction model, or the purpose of harm reduction, is to kind of lessen the use. It may not be total abstinence, may not be the goal. That may be a goal that you eventually work towards, but right now, how can we kind of remove that immediate danger? So people who are using heroin and cocaine, what could we do to make it a little bit less risky or a little bit less dangerous for them to continue their use, but we're hopefully going to get them to reduce that use or use it in moderation. 1980s, a grassroots movement started in the Netherlands and spread to the northern England and later Australia. This was around the time of the spread of AIDS, which was causing more death than addiction. Nancy Reagan Just Say No campaign in the United States came along. The first medically supervised injecting facility in North America opened in Vancouver. This in 2003 to prevent fatal overdoses of heroin. A medical journal found that fatal overdoses decreased by 35% as a result of this facility. Harm reduction model. What can we do to reduce something? Late 1990s, there was about 150 needle exchange programs in the United States to prevent the contraction of HIV/AIDS or hepatitis C. There was a crackdown on doctors prescribing pain pills and making OxyContin harder to crush for snorting or shooting purposes. Another example of harm reduction currently is Narcan or naltrexone. Another example of how the United States is focused more on treatment after the fact rather than prevention. And the harm reduction model wasn't quick to take on in the United States and still isn't quick to take on in the United States. Some states more so than others. For alcohol, harm reduction focuses on preventive measures such as designated driver programs and the promotion of moderate drinking among youth as an alternative to secretive binge drinking. So that might be more popular on college campuses. The popularity of motivational therapy de-emphasizes the use of negative labels and views on substance misuse. So we're finding the strengths and motivation to fight the fight to recovery. And I particularly am fond of that because I don't really like the labels, because I feel like if you're labeling a person, it's making it harder for them to kind of move on or move past it. So to end this video, I wanted to kind of read some, findings from a 2014 study or survey. This survey found a steady decline in the proportion of client admissions for alcohol use compared to other substances. 43% of all clients in substance abuse treatment were in for both alcohol and substance abuse, 17% for misuse of alcohol alone, 39% for drug use alone, 8% of facilities provided medication-assisted treatment, 27% of clients received methadone to prevent withdrawal from heroin, 74% facilities used 12-step focus, 88% used motivational interviewing, 92% used a CBT or cognitive behavioral therapy approach, 12% of facilities had specialized groups for gay, lesbian, transgender, 44% of facilities had women-only groups, 12% had groups for older adults, 12% offered gambling addiction help, 20% focused on family violence, and 71% provided trauma care. So big changes in our treatment from where our treatment started, where we were looking at people as sick, or maybe we were throwing them away to the snake pits, if you will. But just reading those percentages and seeing how much treatment has changed over the years is kind of, a good thing or a positive thing that has emerged from this history. So I wanted to make sure that I emphasized on that so you could see the differences. That is the end of this lecture video for Chapter 2. So thank you for watching.